So welcome, Dr. Ng.
Thanks, Sophia. Delighted to be here. Just apologies in advance. I got a terrible cold, so I've been coughing all day. So if I continue coughing during the presentation, just apologies for that. So I'm going to try and share my screen now. Let me know if you can see my slide set.
Yes, we can see a slide set, so all working well. Thank you.
Great. So thanks for the invitation. So I'm Fu Siong Ng. I'm a cardiologist and cardiac electrophysiologist, and I look at ECGs a lot on a daily basis. I also lead a group that is currently quite active in doing AI ECG research. So my task is to try and talk to you about a system on how to read a paper that uses AI or machine learning. So I think Manolis has given us an excellent sort of starting point to it and covered the basics. I'll hopefully expand on that and teach you how to read a paper on AI and machine learning. Now, why is that important? So if you go and look at all the paper that's been published on the search on PubMed, you can see if you just type machine learning and cardiovascular, so not outside of cardiovascular space, you can see that there is a literally exponential increase in the number of papers. So about 10 years ago, you would see 13 papers in the entire year. And just last year, there's a 100-fold increase, so 1,300 papers. So this is truly the definition of exponential, and this will only continue to increase over the next 10 years or so. And I think as professionals that work in the healthcare space, we can't get away without knowing some of the basics about how to read these papers, like how we need to understand how to read papers on clinical trials, understand the results. We now need to have some basics on how to read papers that use machine learning, determine whether the results are any good, because we need to understand what they mean and how that influences our practice. So if you have ChatGPT, and I have a subscription to ChatGPT, if you ask it what is artificial intelligence, it will give you this definition. Again, Manolis covered it. But essentially, AI is a very broad term that says that a machine can simulate human intelligence and is programmed to think and act like humans. And that is just a very broad, overarching term of AI. But within AI, there are lots of different subcategories that we'll come on to. To say AI basically are just machines that are programmed to carry out tasks like humans. So at the most basic level for an ECG, you can program a machine to separate out ECGs that have a broad QRS from those with a narrow QRS. So look through 1,000 ECGs and tell you these are long QRS, these are normal QRS. And that is some level of AI. As you heard, linear regression is a form of AI. Then you've got machine learning. And there's sort of two levels here. There's sort of the more simple form of machine learning, like random forests. And in terms of AI ECG, what we really describe for a lot of the time is this sort of deep neural network and deep learning. I'll cover that a little bit going forward, and Manolis covered that earlier. And as you mentioned, one of the commonest architectures is CNN. We'll come on to that a little bit, but the other sort of unsupervised approaches like autoencoders. Why are we suddenly all very interested in AI ECG? I think there's been this growing interest in the last 5 or 10 years because we've all now seen the potential of this technology. About 10 years ago, the Mayo Group started this off by describing papers that showed that some models can predict future disease quite accurately. So you take a sinus rhythm ECG, and they can tell you what your risk is of developing atrial fibrillation in the future. And that was just the start of it. What we've learned in the last 10 years is AICG can do lots and lots of wonderful things. It can diagnose LV dysfunction. It can predict future LV dysfunction. It can diagnose and predict valve disease. It can predict future atrial fibrillation. It can pick up peripartum cardiomyopathy, sepsis, even non-cardiac diseases like diabetes, kidney disease. All of that information seems to be contained within an ECG. Clinicians can't pick that up, but a model, an AI model, a deep neural network model, seems able to learn the subtle features that can diagnose these conditions and pick up the risk, and hence this growing interest in AI ECG. So therefore, all the more important that all of us have some framework that can guide us on how to read a paper using machine learning methods. So here's the overview and a structure of how you want to read a paper that is using AI and machine learning. Like any paper, you want to understand the problem that's being addressed. You want to understand what data they've used to put into this. You want to interpret the results they describe. and what they mean, and then evaluate the conclusions. Do the results justify the conclusions? We'll come on to each of these in turn as we go through the presentation. The first step is understand the problem. So when you pick up a paper on machine learning, you want to understand, what is it the problem that they're trying to solve? Is it a big problem? Is it a problem that relates to you and your hospital? Is it something that doesn't really exist, that they're trying to contrive a problem so they have a solution to fix it? What is impact if you can solve this problem? If you have a great AI model and you solve this problem, how much does it help you? Does it relieve your day-to-day pressures at work? Does it improve patient outcomes? What can that do for you? And then you want to do is look into the quality of the data. You've heard earlier that machine learning involves feeding the model with a lot of data and allowing the machine itself to learn patterns on the ECG, for example, that can associate with outcomes and future risk of disease. And therefore, your model, no matter how good it is only as good as the data that is being put in to the model. And there's this phrase, garbage in, garbage out, or rubbish in, rubbish out. If an amazing AI model and your data you put in is poorly labeled, incorrect, lots of missing data, what you're going to get out at the other end is a model that doesn't really work very well. So if you're reading the paper, you want to dig into the details and say, what data have gone into this model? How has it been trained? And from that perspective, you want to assess the sample size. So these deep neural networks often require large quantities of data. They're very data hungry. The more data you feed the model, the more likely it's to learn subtle things and perform well. So you pick up a paper and say, I trained this model using 10 ECGs. Immediately, you're going to think, hang on, I don't really believe the conclusions, because you really need tens of thousands, hundreds of thousands of ECGs to train an accurate model. You want to make sure the quality, the data is relevant, accurate, not biased. We'll come to this in more detail. So in order to explain how to read a paper, I will sort of sometimes refer to one of our papers we published recently and we train a model using 1.2 million ECGs to try and predict when someone might die from an ECG. So it gives you a longevity prediction saying this person from an ECG has 10 years to live, 20 years to live, or 5 months to live. And I'll use sort of text that we publish to try and guide you as to how we would read the paper. So I said, the first question is, how big is the sample size? If you pick up a paper, you want to say, have they put in enough data for you to think and believe that they built a model that works broadly and can be generalized to lots of other situations? As I said, they're very, very data hungry. So in our paper, as I said, we use 1.2 million ECGs from 200,000 patients. You think, okay, fine, this seems to be okay. A lot of ECGs have gone into this model. It probably will train well, have quite good performance. The next question is, are the data relevant? So if your aim is to take an ECG in primary care to predict disease, you want to make sure that the training involves putting in the right form of data. If you just put intensive care data in, then it's not going to work in primary care. So you want to make sure that the relevance of the data are there. So in this case, we took a hospital data set, and the aim is to train a model that can predict from hospital ECGs when someone might die. So yeah, there's some relevance to that, but you want to check and make sure it's entirely relevant to the task at hand. Thirdly, you want to see how accurate the data are. And with this, I mean the labels of the data. We normally talk about supervised learning, where you label the data set and you tell the machine the answers, and it learns to associate the ECG with the answers. Now, if your answers and your labels are wrong, it's going to significantly confuse the model. So you want to check, how are the data corrected and how accurate are they? Were they guessed by someone else not involved in the care of the patient? Were they labeled during the patient's stay? Were they inferred somehow? Were there sort of lots of missing data filled in using some algorithm? How accurate, how much do you trust the labeling of the data? Was there any NLP, natural language processing used? How accurate is that model? Were they using disease codes? We know there's some inaccuracy with disease codes, with billing. In our paper, we use disease codes, and they're about 90% accurate. So you've got to take these results with a pinch of salt, because they're not gold standard labels. They were based on disease codes. So there's some level of inaccuracy. So you got to be mindful of how you arrive at the labels. Then you want to see whether the data are representative, whether there's any bias in data. Because if you train it with only a snapshot of data, you might have a very biased model. There is this famous example that trained a model to pick up malignant skin lesions. And this is about the ruler, this is about the training data set. And what they found was, in this example, they had put in a lot of data from fair-skinned individuals. So the model was able to pick up what melanoma looked like in someone with fair skin. But when you put in a test set with someone with dark skin, the model fails because it's never seen a dark skin image. So it doesn't know what to do. So you're going to see, is the training data set representative? Is it broad enough? Does it represent your population in terms of sex distribution, ethnic distribution? Is it capturing enough breadth of the people that are out there? You want to look at sort of minor things like consistency. Are there any missing values? Are there lots of data that are not there? Which again, you have to impute and fill in the blank. That might make the model struggle. And then you want to look at the class balance. Just again, fine print stuff. If you were trying to predict whether someone will die, in the data set, you need to have some people who die. Because if no one dies in the data set, then your model can't learn what are the features of people who might die in the next few years or so. So you need some degree of events in the training cohort, but you also want as balanced a data set as possible in terms of the disease and the healthy, so the model can see enough healthy examples and enough disease examples to learn the differences. So that's the data. So I always look at the data. Is it good enough? Is it a large enough data set? Is it relevant? Is it biased? And I make my mind up about whether or not that paper is worth reading on. So say you pick a paper, you think, fine, they've got enough data, good quality. Next thing you want to know is what they actually did. And here there's no getting away from understanding a bit of machine learning terminology. As Manolis mentioned, there are two types of machine learning broadly. There's supervised and unsupervised learning. Supervised learning forms about 90% of AICG work. And this, broadly speaking, is a situation where you tell the machine the answer. So you're supervising it. So in this case, you're teaching this toddler what's a circle, what's a triangle, and what's a square. And the machine or the toddler learns to distinguish a circle from a triangle from a square, and then it will do the task properly as it goes from here. In unsupervised learning, it's a little bit different. You tell the toddler, there are lots of different shapes here, but not teach you what they are. You separate out things that look different to you and put it into different buckets. And again, the machine or the toddler, without being told the answers, can pick out all the circles and put it together, pick out all the triangles and put them together, and put the squares together. And that's unsupervised learning. That's useful for clustering disease, where you don't know the labels, but you want to pick out different patterns and groups of patients that have very similar looking ECGs or similar looking data sets. You want to then understand how they train the model. And it's very important here to understand how they split the data. So normally you have 1 million ECGs, for example. You want to be able to split the data into different stages of the process. So often you have a bulk that's used for training. So the machine looks at all this data and it learns to tweak its model weights to try and make its predictions. You want to reserve some of that for validation. So you've done the training, you want to then check and say, how good is it doing? And if it's not doing that great, you go back and you tweak your training. You do multiple rounds of training until you get to a model that you are very happy with. At that stage, it's very important to have this, what's called a holdout test set. This green set of data cannot be exposed to the machine at any point in the past. Because if it's seen it, it'll know the answer. So you need to hold out a test set that's never been exposed to the model. And once you trained it after multiple rounds and you're absolutely happy with it, you do one run of testing on the test set and say, okay, now that I've trained it, I'm going to do one round of evaluation. How good is my model in picking up future atrial fibrillation, in picking up undiagnosed heart failure? And you report the metrics from this green data set, not from any of the stuff up here. If they don't do this, then they're doing something a little bit dodgy, and you've got to be aware and open to these possibilities. More and more nowadays, you have to test it not just within your data set, reserved from your own data set, but also look at an outside data set to see how well your model can generalize to a different setting. And we'll come into that in a little bit more detail. So in our example, we split it 50, 10, 40. So 50% we use for training, 10 for validation. We saved 40% of the data for the final test at the end to see how good the data were. And you need to make sure there's no data leakage or crossover between these data sets. So each patient can only be in one of these bins. Otherwise, there's something called data leakage, and it might affect how it might artificially inflate the performance of the model. And then you want to understand what approach they use. Manolis mentioned different types of machine learning approach. Most AICG uses deep learning, and there's a CNNs and RNNs and GNNs. Again, I won't go into detail here, but there's slightly different ways of handling data inputs and processing them to make predictions. As Manolis mentioned, even the regression model is an AI model, but more and more the deep learning models, as he showed, takes an image, breaks it down into different constituent parts, and then combines them to higher level features to help it make a prediction. So this is done simplistically usually in this example. So if you want to train a model, a CNN, to distinguish a circle from a cross, you use a supervised approach. You basically show the model 100 crosses and you say, these are crosses. And you show the model 100 circles and you say, these are circles. And that's all you ever need to do to train the model. The model will then do its own thing. It will break down the image into different parts of the circle and the cross. And it will learn on its own without the human teaching it that if it sees only diagonal lines with no horizontal and vertical lines, it must be a cross because it's learned this and it's only seen these features in the cross. And if it sees horizontal, vertical, and diagonal lines, it will say it's a circle. And very quickly, your model will be able to distinguish a circle from a cross without the human needing to do anything. So you can see at a much higher level, you can train a model to pick up disease from no disease, heart failure from no heart failure. All you need to do is tell it the answers and give it the ECGs, and it will learn over multiple rounds of training what are the subtle features that distinguish someone with heart failure from someone without heart failure on ECG, and it will learn new rules that a human may not be aware of. So once you understand what was done, you want to evaluate the results. You want to understand what the results actually mean and how good is the model. And machine learning results are not too dissimilar from other formal results you might read in the literature, but they basically report how good the model is at predicting an outcome. So if you are trying to predict a continuous variable, say you want to predict someone's weight or height from the ECG, it'll output a number rather than a yes/no answer. So you want to see how far that number is from the real number, the actual answer. And from that, you can calculate how much error there is from the output number from the machine, from the actual number. And these are some of the metrics you can use to calculate that. If the output is binary, so heart failure or no heart failure, that's a classification task. That's not a continuous regression task. In this case, you want to see how often they get it right and how often it gets it wrong. And Manolis showed you confusion matrix in a bit, but here are some of the things that how you can report a binary classification or multi-class classification task involving true and false positives and negatives, or some of the more machine learning specific metrics like F1, score, precision, recall. Manolis covered this, as I won't go into too much detail, but you can work out how often the machine, if the machine says there's heart failure, how often it gets it right. If it says no heart failure, how often it gets it wrong. And you can report these metrics and evaluate how good that model is in doing the task that you want it to do. You can use something called a seed statistic, which is discriminatory statistics. We use it a lot in predicting future disease, in predicting risk. If you want to predict whether someone might die in the next 5 years, and you want to compare two individuals, can you discriminate between the higher and the low risk individual and how well you get it right? It's a bit like an AUROC metric. 0.5 is a flip of a coin, 1 is perfect, and getting to something like 0.8 would be pretty good. And this was the results from our mortality prediction model, where about nearly 80% of the time you can discriminate a high from a low risk ECG in terms of the risk of death. There's some other stuff that you want to look for in the supplement. So you can look at evidence of this is the training curves, and you can see how the model is training. But there's something you need to worry about, which is something called overfitting. So as Manolis said, these models are so complex, they can learn pretty much every single small feature of your data set. Sometimes it overlearns. So you might say that's not a bad thing, but actually it is a bad thing because it learns things that are so specific to your training data set that it might not be able to generalize to any other data set. So it might learn everything specific to your patients in your hospital. And it's so fixated on all those things that when you try and test it in another hospital, it just doesn't work. And that's the case of overfitting the training data set. Last thing, you also want to see whether it was externally validated. So this is very important these days, and Manila's hinted at that. If you train a model, you really want to see how well it works outside of where it was trained. Can it work elsewhere? In another hospital in your city, in another part of the country, or in another country, in another continent? Does it generalize to other populations, other ethnicities? Is it going to work if you take it somewhere else and use it? So in our study, we actually did that quite widely. So we trained it in a US cohort, but then tested in 3 Brazilian cohorts and a UK cohort. So we were confident that the model actually works very well in any setting. So we tried to predict mortality. And here you can see the Kaplan-Meier curves that shows the highest risk predictions from AI-ECG. Having trained in a US population, we tested in a Brazilian volunteer cohort, a Brazilian GP cohort, and a Brazilian heart failure cohort, and a UK volunteer cohort. And it seems to work pretty well. In every situation, the high-risk individuals discerned by the AI model seems to die a lot more. So we're happy that this was the case, but you should always check how well it was externally validated. And then Manoli said it's important to have some explainability to the data. And that I think is also very important. As a clinician, we want to understand that these models work in the way that we can relate to. There's this excellent paper, editorial in circulation that was entitled Trusting Magic, which accompanied an AI-ECG paper. And it says that a lot of these models seem to be a bit like magic, and we are being asked to just trust them and use them. Of course, clinicians would accept them a lot better, and they can understand how these models are working. Manolis had an example with the ruler. Here's another classic example where someone trained a model to distinguish a wolf from a husky. And they look kind of similar to the human eye, but the model works very, very, very well. It's able to distinguish a wolf from a husky 99% of the time. But when you interrogate the model and see what it's looking at, it's not even looking at the face of the animal. It seems to be looking at the background. So if it sees snow, then it will say it's a wolf. If it doesn't see any snow, it will say it's a husky. Then, of course, it's nonsensical because you put them in a different environment, you'll get it wrong. And probing the black box and understanding the predictions and how they make it is very important to gain trust of physicians and healthcare professionals. How do we do it? We use something called a variational autoencoder that breaks down the ECG into different morphologies. You heard about saliency mapping that highlights the important bits of the ECG, but it doesn't tell you what shapes of ECG are important. So using a VAE approach, you can look at the high-risk shapes and the low-risk shapes. So in this case, we looked at the risk of mortality, risk of death, and the sort of red shapes are the worst. So the broad left bundle lunch block ECG seem to be highest risk. The narrow QRS is low risk. If you have odd shaped T waves, that appears to be high risk. A normal upright T wave is good. And then sort of SD segment changes clearly are bad. Normal segments are good. So this gives you some explainability about the model, but there's always this trade-off. The more explainable your model is, the worse it performs. So you have to find the happy medium between performance and explainability. And then finally, once you've read all that and you're happy, you want to understand, well, does it mean anything? So is this model even useful? So they may have done it well with good data and externally validated it, but is it even useful to you? You want to work out. Can it be deployed in your healthcare system? Do the data inputs exist? So some of these models are trained using digital ECG. So if you're GE Muse, that's great. You can take digital XML and put it into the model. But lots of healthcare systems have paper ECG. So no matter how good the model, it's not really relevant because you can't use the model. Where would you use it? Would you use it in CUG pre-practices? Would you use it in the hospital? Would you integrate into electronic health records? Would you use it as a separate web app? All of those things you need to then evaluate and work out whether or not it's useful. So I'll leave a few minutes for questions, but that's sort of my framework. I think we can't get away from learning how to read these papers. They're here to stay. More and more papers will use machine learning and AI methods, and we have to have a framework. And the framework, I guess, is very briefly summarized as follows. Understand the problem, look at the data. How good are the data that have been put in to train the model? What methods did they use? Are they valid? And work out the results. Make sure you understand how they're presented, and then work out whether the conclusions are justified by the results. And that was I guess, a short 25-minute guide on how to read a paper on machine learning. Thank you very much.
Thank you so much, Dr. Ng. This was really a great example on how to actually understand all of those papers out there and what we can trust or not to trust. Are there any questions from the audience? I don't see anything in the Q&A so far, but happy if you would have some questions. We have a few more minutes before we need to transition to the next session. Meanwhile, I actually wondered, so you talked quite a lot about what is enough amount of data to actually look at. So is there a golden standard, or as much as possible, what would be enough when you're trying to collect data for actually testing this?
I mean, that's an excellent question. I guess there isn't a real fixed answer for that. It comes down to the task and how subtle the features you're trying to look for. So, for example, the task about a cross in a circle, that's very simple. So you probably need tens of crosses and tens of circles, and it's probably enough because they're so different. If your task is to distinguish, left bundle branch plot from narrow QRS. Again, it's quite different. One is quite broad, one is quite narrow. Maybe you need a few hundred, up to 1,000. That might be quite good. If you want to detect undiagnosed heart failure, where it's very, very subtle, you might need thousands, tens of thousands, or hundreds of thousands. So it depends on the task at hand. I think the easier the task, the smaller the number. But rough ballpark, if I see things that are in the hundreds, I think, well, this is probably not going to work. You need thousands, tens of thousands, our stuff in the millions. Most places I read now, hundreds of thousands to millions of ECGs. And again, that's the strength of GE Muse, the ability to export large quantities of data, train them, test them. That's why we need a digital ECG system.
Thank you very much. Makes perfect sense. Thank you. Any additional questions from the audience? Or everything was just quite clear when you explained, so now we all know what we need to look out for when reading those papers that are out there.